going to start the next session, and we are really have the pleasure to have Dr. Samrat Jankar again in our Sudanese Surgical Club. We enjoyed your first presentation about colorectal cancer, and I'm sure that everybody will enjoy this second presentation. Mr. Dr. Samrat, the floor is yours. Thank you very much.
Sir, should I start?
Yes, please. Yes, please.
Yeah. Thank you for giving me opportunity to glad Raj sir was my one of the teacher. I was joined for this session. It was excellent, wonderful session. After such a talk, I think finish up as quickly as possible. Surgeon will get in the OPD.
Sorry, sir, your voice is not clear.
One of
Dr. Jankar, your voice is breaking. I think we have a problem with the connection.
got disconnected.
It's all right. Okay.
Yeah. Fistula in ano is one of the common surgical problem. Every colorectal surgeon or every general surgeon will get in the OP. And it is one of the complex problem. If we won't understand, we'll see that we should send to someone else. So we'll talk briefly about the concept which I learned from my teachers. I am basically from Symbiosis University Hospital, which is located in the Pune. And this is my hospital. Greeting from the Symbiosis University Research Center. So we'll start with knowing the what issue are there for treatment of complex fistula. We'll see issue number one. For treating any complex fistula, there are n number of surgeries there. A lift, a fistulotomy with immediate sphincter repair, perfect, waft, advancement flap, set-on, and fistula plug and stem cell. And n number of surgery I have not listed. There are also there n number of people are telling there are many good success result. But no single technique is appropriate for management of all complex fistula. Means this is a problem where we can't achieve 100% result. So a number of surgeries are there. But for my personal opinion, in last 2 years, I have visited Dr. Rojanasakul sir. I have learned the lift. It is giving me a good result. And although there is a good result, around 10% of the patient, I need to do repeat surgery. That kind of scenario I am facing. But I have seen fistulotomy with immediate sphincter repair. One of the master of this surgery, Dr. Parvez, sheikh, who does. And in fact, I have seen the results also. It's really wonderful. So it's kind of many surgeon with many technique are telling that they are achieving best. But the fact is no one is at 100% success for with any technique. So second issue is the reports. Whatever we are doing the imaging, what radiologists give this kind of report. I am just taking for the presentation purpose. When surgeon feel that it is a complex fistula, he sent to the radiologist. And most of the radiologists, few of them gives very wonderful result which will be helpful for surgery. But most of the radiologists gives such a report. Seeing the report again, surgeon will feel that it is a very complex surgery. So they tend to do underdoing for the case. That will be the usually scenario. So what surgeon expect from the radiologist is most important. What any surgery if we are planning to do, we want to know that where is the internal opening. We want to know that what is the relation with the sphincter complex. Is it a high? Is it a low transphincteric? Is it really going to cause any sphincter injury? We want to know, is there any abscess, tract, secondary extension with respect to different anogenital spaces, which in fact is important for avoiding recurrence. We want to know about the external opening, blind ending, whatever is there, we want to know. Third issue is classification. There are a number of classification. The classification purpose is to simplify, standardize the communication between the clinicians, radiologist, and the surgeon who is operating. They should guide the clinician about the complexity and also appropriate treatment option for that particular case. The guide surgeon to estimate the surgical success, so that frankly tell to the patient before doing surgery we can counsel, and also possibility of the post-surgical sequelae, that's especially incontinence. That is much more important if we are handling the complex fistula. These are the purpose we should get from the classification. But we are having old PARC classification. In fact, it is a best classification. One at that time tried to do something which is commendable. It is a purely surgical classification based on the physical examinations or intraoperative examinations. It's a most easy and most simple classification. It's based on only coronal plane what surgeon sees. But this is done in the pre-MRI era, where we have bit less understanding about the complexity. Modern fistula and whatever there 70 that time, it was a pre-MRI era. And mixed type of fistula in every class. We can see if PARC is telling that intersphincteric, it may be low intersphincteric fistula which is going down, which is simple fistulotomy cancer. But in PARC classification, intersphincteric, high intersphincteric fistula also classified as intersphincteric, because high intersphincteric fistula treatment option will be different, low intersphincteric fistula treatment option is different. We see this is a low transphincteric fistula which is going down. Without any risk of injuring sphincter, we can cut down. But if it is high in transphincteric fistula, that we can't go with sphincter cutting, which will definitely land in disaster. So they are not giving us classical idea what we should do, and data is more obscure. Whatever they have classified, more patients are in the type 1 and type 2, less patients in type 3 and type 4. In fact, it is more towards the intersphincteric and transphincteric. And extrasphincteric, suprasphincteric type usually iatrogenic. Extrasphincteric, suprasphincteric has been mentioned in the PARC, but in fact, the more papers of the PARC are not consistent with the incidence of extrasphincteric, suprasphincteric. And recently, Gerg from India, who has done lot of fistula cases, they have told that it's extrasphincteric, suprasphincteric. They have not found in even in one case. It might be most probably iatrogenic. Most of the studies are also mentioned about the same. If we take a St. James University Hospital classification, this is one of the very good classification which most of the radiologist follows, and most of the radiology gives us report in the St. James University classification pattern. This is mainly MRI based classification, but same from the same university hospital, and it is a most usually rampantly used by radiologists to give a report of the fistula to the surgeon. But is this going to solve? Is it solving our purpose? No, it is more or less PARC. Let's see, it doesn't help much in surgical planning. It has classified type 1 intersphincteric into type 1 intersphincteric simple fistula or associated with abscess or secondary extension. So both treatment for the intersphincteric fistula, if it is coming a low, then fistulotomy will suffice. It is not much different. It is a type 1 of PARC has been divided into type 1 and type 2 of St. James. If we see type 3 of St. James, that is a fistula. Type 4 is an abscess or secondary extension. It means that type 2 of PARC has been classified into another two type in the St. James. And what they have done, the type 4 and type 3 of PARC, suprasphincteric and extrasphincteric, they are clubbed as a type 5. So it is more or less kind of PARCs only, which is also not giving us much idea what we should go ahead. Means it is not simplifying the concept, or it is not guiding properly for us. And most of them are concentrated towards what is a risk of complexity rather than surgical planning. So issue number 4 is Dr. Alan Parks' contribution for the fistula is tremendous. What his statement is, it's impossible to perform the without accurate anatomical knowledge. This is particularly true in case of fistula, where intemperate surgery can lead to disastrous results. It's really horrible if we land in incontinence, it's really horrible. Or even if we are landing simple fistula is turning into complex and complex, it will be really disaster. So with this problem, we will going to see what can be the best solution. I am really thankful to Dr. Parvez Sheikh and Dr. Arun Rojanasakul. In fact, in last 2 years, I visited both of these, my mentors in this study, and I have learned lot of things from them. And whatever today I am presenting concept are belong to these two teachers. So these are most of the concept belongs to Dr. Arun Rojanasakul sir and Dr. Parvez Sheikh sir. And Dr. Arun Rojanasakul sir was so generous. He has even given his material to share with many of the people so that concept will reach many of the people. So we'll see. Let's see all 4 issues one by one, how we can simplify with this concept. So for this anatomy, we need to understand in better way, which is for the fistula treatment. So they have simplified sphincter anatomy of anal canal by Rojanasakul sir. In fact, they have published in 2016 in International Journal of Colorectal Surgeon. What they have mentioned is perianal anatomy for fistula purpose we can take into 3 heading. One is anogenital muscle, second is anogenital fascia, third is anogenital spaces. Let's see one by one what is happening. Anogenital muscle, we all know that internal sphincter is nothing but the continuation of circular muscle of the rectum. External sphincter is nothing but the levator, continuation of the levator. But surprisingly, in 100 of cadaver, they have done dissection and they found out that there is only 2 components of external sphincter, that is a superficial and subcutaneous. In fact, deep component is continuous with levator ani. So he feels that we should not label a deep component as a separate, rather than we label as a levator part, so that we can tell that if something is going towards the levator, going towards the deep, which will be the more complex fistula. So, and they have proposed the 3-level concept of anal striated, anogenital striated muscle. There are 3 level, upper, middle and lower level. In fact, it is most important to know whole the concept of fistula is revolving around this concept. So upper layer is levator, which is starting from the coccyx and going towards the pubis, and it has a 3 component: ileococcygeus, ichthyococcygous and puborectalis. And second layer concept is our superficial external starting from that ligament, and in front it is coming for the perineal membrane that will be separated by the superficial transverse perineum. Lowermost is the subcutaneous external sphincter, anteriorly presented by bulbocavernosus. So lower level is subcutaneous external sphincter, which can be divided in any case without any fear of incontinence. But if it is a superficial external sphincter, specifically if it is a female anterior fistula, if it is associated with IBD, if it is associated with any other complexity, we should be cautious for dividing even superficial external fistulas. And levator, we should avoid to touch this layer. Definitely, if we divide the levator, we land in incontinence, which is most disastrous of fistula treatment. So this is one of the cadaveric dissection image shared by Rojanasakul sir. You can see here the levator ani upper muscle, and second striation is a superficial external sphincter. Third striation is the subcutaneous external sphincter. We'll see anogenital fascias. There are 3 genital fascia which divides the perianal spaces into different perianal space into different spaces. There is a intersphincteric fascia which is there in between the 2 muscle, internal and external sphincter. There is the transversalis fascia which is running transversely, and another one is running obliquely, ischianal fossa fascia, start in between the levator and superficial external sphincter junction, and goes towards the obturator internus. If you take this of ischianal fossa fascia, which divide lateral space into infralevator and ischianal spaces. Sometime we may get a patient where we are having a tenderness in the ischianal fossa, but there is no palpation, and sometimes we also explore, we are not able to see any abscess here because this is a deep loculated abscess because of this fascia which is holding down, and it can be traced on UVG or deep. If we dissect, we can get it. And transverse septum fascia, which divides the ischianal fascia and perianal space. We'll see the anogenital spaces divided by this fascia. The anogenital spaces, one which is above the levator is a supralevator, one which is below the levator is a infralevator, one which is below the infralevator in between the ischianal fossa fascia and transversalis fascia is ischioanal space, and in between the two sphincter is a intersphincteric space. And around the anal region and around the subcutaneous part of external sphincter is your perianal region. The posteriorly will have a deep postanal space, and anteriorly around 11 to 1 o'clock we'll have a perineum space. In this, we can see the bulbocavernosus and superficial external sphincter. Down is a perineal space and followed by the subcutaneous external sphincter. Here is a perianal space. The perineal space is contralateral to superficial external sphincter. Deep postanal space, we can see here anococcygeal ligament, both side ischianal spaces, and below that we can get a deep postanal space. And in this, we can see that in the coronal plane, levator muscle is there, superficial external sphincter, subcutaneous external sphincter, superficial external sphincter. This is a deep postanal space. In fact, deep postanal space will be connected with both side ischianal spaces, which will make a horseshoe abscess on either side or both sides. We can see the natural abscesses around the perianal region in the particular spaces. This is intersphincteric and perianal, ischioanal, infralevator, supralevator, and deep postanal and perineum spaces. Aim of any fistula surgery is to eradicate the sepsis, promote the healing of the tract, and avoid the incontinence. This is the primary aim of any surgery. Successful management of the fistula in ano depends upon a good, proper surgical technique. I think there is a lot of evolution has happened in fistula surgery. Lot of techniques are there, and in a particular expert hand with any technique, we can get a good result. But other than that, other two factors are also important in fistula, is accurate preoperative assessment and also good postoperative care. But in surgical domain, we are having this, we can improve our surgical technique, we can improve our good postoperative care, but we need to have a good preoperative assessment, means good preoperative imaging to tell that what is happening in the perianal region. The best modality of evaluation of the fistula and ano is digital rectal examination. In fact, I have seen 2-3 cases when I visited Dr. Parvez Sheikh. Once he put the finger, he will draw what kind of fistula, even it is a high or low, and he believe that his finger is more better diagnostic modality than the imaging. And in fact, it is true. If a trained finger is there, it can work, but it is difficult to have such a trained finger in everyone's hand. We need a proper imaging. In fact, fistulogram has been told there is near about only 16% sensitivity. If we do scan, a good scan radiologist is there, we can get around 70 to 80% good sensitivity in UAG. But MRI is it's not operator dependent, and lot of things are evolving in MRI. We can get a good imaging if we are comfortable, like a CT or MR rectum in MR fistula. Definitely surgeon can give a good justice for the complex fistula, avoiding suffering. So what is a term complex fistula? When fistula is termed as complex fistula, we know that if it is anterior fistula in female, recurrent IVS operated fistula which is coming with a recurrence, or patient with incontinence, local irradiation, Crohn's disease, or tract crossing more than 30 to 50% of external sphincter, or multiple tracts or associated multiple hidden abscesses. So clinically, we can see these first 3 components, but we expect from the radiologist that last 2 components should be told by radiologist what is a complexity. So it is a good study has been conducted in 2002 telling that if the recurrence in recurrent fistula, MRI, role of MRI in recurrent fistula, if surgeon always act on MRI, specifically case of recurrent fistula, chances of recurrence is 16%. If surgeon never act on MRI, chances is around 60%. And surgery guided by MRI will reduce the recurrence in 75% of recurrent fistula. So they conclude that in recurrent fistula, we should do the MRI. In fact, all complex fistula should get MRI. In perspective of if we are having study or anything, doing MRI in all cases also, if feasible, will be a good advice. It will be good acceptable, because one recurrence will have a lot of trouble to the patient. Maybe MRI may be cost effective if we consider same thing, but simple fistula can be operated without MRI also. So we have seen this kind of MRI report, which will make us more complex because they are giving a more complex report. So we need something which we should get from the radiologist. That's what the fistulogram, MR fistulogram for the surgeon. So we should understand the basics of MRI so that we will be more comfortable with MRI. So we'll touch the basics of MRI in fistula. So what sequencing they do is T2 sagittal, axial, oblique T2 coronal, fat sat, oblique T2 axial, fat saturated oblique T2 coronal, or stir images we can call this. So T2 images mainly for the anatomy, T2 with fat suppression so that we can reduce the hyperintensity. We can see fistula tract mainly, that is fat saturated or stir images we can get. So sagittal view mainly for getting orthogonal plane where we want oblique axial or oblique coronal. Sagittal film first will help, and oblique is mainly for relation to the sphincter to understand, coronal to know the level of internal opening, relation of sphincter, levator ani muscle, and contrast intensity. T2 fat saturated or stir images are good enough, but if we are having contrast, it can be used. In contrast, we have to give in T1 weighted contrast images, which will help in better appreciation, and also diffusion weighted images, 3D images, that are additional gadget. But basic requirement is T2 and T2 fat suppress, or T2 and T1 contrast images may suffice for us. So basically the second images are mainly for the axial cut. We are going to get the oblique cut so that we will get the proper relation. These are the coronal cut we can get. So basic understanding, where is the internal sphincter, inside is the internal sphincter, and next one is the external sphincter, white line which is prominent, which is the intersphincteric phase, and lateral area is our ischianal spaces. A coronal also we can understand these all the structures. So we want the radiologist should talk on anal clock so that they are doing most of the time what level is there, and according to anal clock they will give us the reports. So Dr. Arun Rojanasakul sir has proposed the concept of fistula mapping. Fistula mapping, in fact, how the radiologist and the surgeon should report the fistula finding so that there will be something uniformity which will be both are talking in same language, which may improve the practical problems of fistula recording. So this is proposed by Dr. Arun Rojanasakul in 2017. It is basically a template to record and report the anorectal sepsis. In fact, if we tell abscess and fistula different, it will cause a confusion. It is nothing but it's a complete perianal sepsis or anorectal sepsis. So why MRI fistulogram is not well accepted in surgical fraternity? The basic is surgeon and radiologist, we are having very weak link. If we take a CA rectum, whatever T staging we are telling clinically, radiologist telling on MRI, and also the pathologist telling on the pathological specimen, both everything is almost matching to everyone. So surgeon will read the MRI and he will better appreciate what's happening. If we take any CT, what we want, that thing we are getting from the radiologist, we will be very happy to read that. But here the weakest link between the surgeon and radiologist regarding MR fistulogram is there is no universal accepted communication between the two treating physicians. So that's the major problem why MRI is not well accepted in the surgical fraternity, although it is the gold standard investigation. So anal fistula map, this is nothing but document the passage of anal sepsis from inside to outside and describe the direction, how tract is going. Is it going high? Is it going down? And what is the relation of the mainly sphincter, means external sphincter, and also abscess or cavity or tract while it passes from start to end, that we need to document, so that it will be very easy for the surgeon to know that what's happening for the patient. So to understand either in the lithotomy or prone position, we have to take the fistula map. This is the pro forma. Few of the abbreviations are there. Until and unless we know the abbreviation, it's difficult to understand. So let's see in next 3 slides what are the meaning of this abbreviation. IO is nothing but internal opening, EO is external opening, B is blind ending. External side, it may be external opening, it may be blind ending. T for the tract, C for the cavity, A for the abscess. Abscess need to be drained, cavity need to be drained, curated, and we need to put a draining catheter, and tract has to be ligated if we are doing the fistula, or you are tackling by any other method which is better, that also need this information. Next level is how tract having relation with the external sphincter. If it is going in between the sphincter only, that is intersphincteric, not at all crossing the external sphincter. If it is going at the level of subcutaneous sphincter or superficial sphincter, that will be a low transphincteric fistula. If it is crossing above the superficial external sphincter, either at the level of puborectalis or deeper, everything will be the high transphincteric fistula. If it is going through the levator, in fact, the natural passage of the abscess will not go through the levator. Usually translevator will be the iatrogenic fistula. The spaces, we have seen all 7 spaces. What the abbreviation ITS is for intersphincteric space, PRA is for perianal space, ISA for ischianal space, IFL for infralevator space, SPL for supralevator space, PRN for perineum space, DPA is a deep postanal space. So what's the algorithm? We have to go from in to out. So we'll tackle first as an internal opening. On the anal fistula map is not only to record by the radiologist, it should be also recorded by the surgeon. We are doing intraoperatively, we have to record. What we have to see first, we have to see the internal opening. According to clockwise, is it 1 to 12, where it is there, we have to mention. Second, we have to see the intersphincteric space. There, what is a finding? Is it abscess? Is it a cavity? Is it a tract? We have to note. Third, level of the sphincter. Is it going down at the low level, higher level, or is it translevator fistula? Anogenital space. Rest of the 6 spaces, which space it is traveling? That has to be mentioned along with the what is a finding. End point, we have to mention in the clockwise. Is it external opening, 1 external opening, 2 external opening, which o'clock, 1 blind ending, 2 blind ending, which o'clock? So that in crux, if the radiologist give us in this format, surgeon will have 3D map in his mind. There is no need to read long report. If we get a crux of that in this format, you plan any surgery, any kind of surgery for the fistula, all the matters. So for example, we can see this is what the radiologist has given: IO6, ISTT, ST, IFLA, ICA, PRN, T, and EO7. So let's see, we can map out what happening. IO6 internal opening I have drawn at the 6 o'clock. ISTT in the intersphincteric tract, there is a tract we can consider for the left. Then this tract is going high trans, means it is crossing the deep sphincter, it is going above direction. Then infralevator, it is forming the abscess. Ischianal, it is forming the abscess. In the perianal, we can see a simple tract and it is opening at the level of 7 o'clock. All the things are given by radiologist. We are mapping in our mind, we are preparing for the surgery. In fact, during the surgery, surgeon also should, what sir recommends is, during the surgery, surgeon also should report the map, so that we will have a two-way communication with the radiologist that out of the 5 findings, this finding were missing or this finding is wrong. Next time he will be aware that what need to be given in that condition. example we'll see here. IO6, internal opening at a 6 o'clock. Intersphincteric, there is an abscess which is going to the deep post-anal space, reaching to the deep post-anal space, that is a DPA, and there it is forming as an abscess. And in issue-anal space, it is traveling as a tract, and there opening at first opening at a 4 o'clock and second opening at a 3 o'clock. Total distance is around 5 centimeters. It is forming. So these reports will give us mental map. Based on these 3 slides, I am sharing our experience, what has happened in last 1 year, that I will share. We have also started doing this anal fistula mapping in our patient. We are using the radiological map, what sir has taught, and we are doing same thing on the intraoperative. We prefer to do most of the lift. We are doing same on the intraoperative also. And we try to correlate between the 2 maps, irrespective to all the 5 findings, how these radiological reports, are they correctly coming on the table. In 9 months, 37 cases we have done. 4 cases without MRI has been operated in emergency, we excluded. Near about 75%, 76% were male, 23% were female. Median age is 39. 27 out of 33 were complex. Out of that, 16 were recurrent fistulas. Out of total 33 patients, means 165 finding, 8 finding were non-concordance between the radiology and intraoperative finding. First case, let's see what happened to 8 cases. First case, the radiologist has given internal opening at a 5 o'clock, but on a table we tried to inject the hydrogen peroxide, but it didn't came at the internal opening. Considering the radiologist has given intersphincteric tract also at 5 o'clock, we did a lift. We found out the nice tract. We ligated, we cut the tract, and after that we tried to inject the S2O2 from the perianal aspect. We seen that it was oozing in the intersphincteric, means it has been there. Internal opening we couldn't see, most probably might be because of blockage we couldn't see. Second case, we have seen that the patient was having the tract 12 o'clock internal opening and tract at the intersphincteric level, and it was bifurcating into 2, and both the labia were having the external opening. But on the table there was no tract, only abscess was there. Then also we put a tube on the both side, and near about 4 centimeter cavity was there. Internal side, on the internal sphincter side, we ligated the tract. Here a point to note that patient has done MRI 2 months before and came for surgery 2 months later, and in that meantime both external opening were closed, and she is having chronic infection which was collecting the abscess in the perineum space. Because of that we might have not got, so we should do the MRI, and earliest within a week we should plan for surgery, so that it will not going to change much. And other 6 cases, the radiologist was telling sphincter was intersphincteric or low sphincteric, which was not correlating. That I think with more number of cases we will be more familiar with radiologist, and radiologist will be more familiar with the sphincter level, and which will reduce eventually over the period of time. So 95% there is a concordance between the radiological and surgical finding, which is good one, which will help a lot of things for surgeon to understand. So we'll see the anal fistula pattern. This is also concept which has been proposed by the Arun Rojanasakul. In fact, there are many classification are there. There are many drawbacks are there every classification. Rather than telling new classification going to cause new trouble or new misunderstanding, sir has proposed the patterns. There are 5 different patterns of anal fistula, how it travels. So every abscess, if it is a submucosal abscess, it will rupture by itself. Rather than forming fistula, it will heal by itself. But when it goes and locked at the intersphincteric level, then internal sphincter spasm will happen. It may travels in downward direction, which will cause a low intersphincteric fistula. If it is goes upward direction, it will cause a high intersphincteric fistula. If it is caused transversely, it will cause the low transphincteric fistula. If it is go high up through the levator, it will cause a high transphincteric fistula. Let's see what happened to everyone. These are the natural plane where least resistance and naturally wherever a least resistance, chance that on that area the abscess may travel and it will give the pattern. So depending upon this pattern, and in fact if the pattern is in between the two muscle, it will never goes through the muscle. The abscess will travel in between the two muscle and reaches to the space. It will never cross through the muscle. So that's also one of the concept he has proposed. So let's see, if it travels in downward direction, it will be the pattern 1, low intersphincteric fistula. If it travel down through the subcutaneous or superficial external sphincter muscle, that will be the low transphincteric fistula. If it travels anteriorly in the perineum 11 o'clock to 1 o'clock region, and it goes above the external sphincter, superficial external sphincter, that will be the anterior high transphincteric fistula, which goes to the perineum space and perianal space. And if travels posterior, reaches the deep postanal space, travels either on the ischianal or any other side, that will be the posterior high transphincteric fistula. And in fact it will be also high up of the superficial external sphincter, but more on the posterior aspect. And if the abscess goes into intersphincteric and reaches the above region in the intersphincteric space, that is a high intersphincteric abscess. It may form the supraelevator, and sometimes it comes to the parietal wall, abdominal wall also. So these are the mainly 5 pattern, natural pattern, where fistula can, abscess can travel. And in this pattern, we can have either fistula or abscess, which will be highly easily understandable. So let's see what treatment can be done for each pattern. Pattern 1, where it is going in the intersphincteric and forming the abscess, or it is reaching to the perianal space and forming the tract, which is not at all crossing the external sphincter. Simply this patient can be undergoing for the fistulotomy or fistulotomy with immediate sphincteroplasty, that can be done. If we are having low transphincteric, which is going through the subcutaneous sphincter and forming outside abscess or outside tract, this also we can do a fistulotomy. Lift here can be done if patient don't want long cut, or we can do a primary fistulotomy with immediate sphincteroplasty also can be done, and flap also can be done in this type of cases. So anterior high transphincteric fistula, these are the fistula where we need a sphincter preserving surgery. It is going anteriorly above the external sphincter and reaching into the perineum space and perianal space. Usually they will be located around 11 o'clock to 1 o'clock region. These need definitely either lift, flap, or fistulotomy with immediate sphincteroplasty. This is needed treatment for this kind of anterior high transphincteric fistula. So posterior high transphincteric fistula, when fistula is there, which reaches directly to the deep postanal space after crossing the external sphincter, and from there it goes either on both ischianal fossa side and forms the abscess and reaches to the perineum and perianal region to form the external opening, or it may be related with abscess. So these kind of patient are having high transphincteric, high transphincteric above the superficial external sphincter, which is reaching into the posterior deep postanal space. These patients definitely need a sphincter preserving surgery, lift, flap, or fistulotomy with immediate sphincteroplasty, or Henle fistulotomy can be done. Also, they have seen some of the cases pilonidal sinus we may consider, but it has a long tract which is going from the deep postanal space and reaching to that area, and this is also one of the type of fistula. It is a part of the type 4. Here also we can do the lift and we can solve this problem. But some of the patient, if having posterior high transphincteric fistula, reaches the intersphincteric space and comes out, those are also possible other alternative in pattern 4. Pattern 5 is the abscess reaching from the posterior region, reaches in the intersphincteric and goes up and form the supraelevator abscess, or it may be a intersphincteric abscess may be formed. This can be tackled with a lift and tube drainage, or intraanal fistulotomy, which is also one of the good surgery where we can put our probe into the intersphincteric and divide the internal sphincter and marsupialize the edges, which will help in hemostasis and also which will help avoid the recurrence, which is also one of the best modality of treatment for type 5 high intersphincteric fistula without any incontinence. We can have pattern 6. It can be a combined. Most common combination, which is highly complex and most obviously going to have a recurrence, is a posterior high transphincteric with high intersphincteric. We are having a posterior high transphincteric, which is a risk of incontinence, and also having high intersphincteric, which is one of the most common combination pattern. But other combination, anterior high transphincteric combination with high intersphincteric, also possible. In these cases, what has been recommended by Dr. Rojanasakul sir is either you do lift with tube drainage of whole abscess is also good, or you can do intraanal fistulotomy for this, and you go outside and tackle this by taking a XE lift, that is a extra sphincteric outside going and tackling this fistulous opening. That also can be possible. So fistula pattern and operative option by the Arun Rojanasakul sir has been proposed, that is low intersphincteric we can consider fistulotomy, or if patient want early wound healing, the fistulotomy with immediate sphincteroplasty also is feasible. Low transphincteric we can do fistulotomy, lift, flap, or fistulotomy with immediate sphincteroplasty. Anterior high transphincteric, these are the riskier patient. If it is especially female patient, we should prefer for a sphincter preserving surgery, that is a lift, flap, or fistulotomy with immediate sphincteroplasty. Posterior high transphincteric we can consider lift, flap, or anything sphincter preserving we should consider. High intersphincteric, intraanal fistulotomy is a wonderful procedure, and lift also can be done in this patient also. And if it is a type 2 and type 5 combination, which is the most difficult to treat, in this patient we can consider intraanal fistulotomy with suturing of the external sphincter from the ischianal side, ischianal fossa side, or we can consider the lift or fistulotomy with immediate sphincteroplasty. That is also one of the good option for this kind of cases. So a few surgical procedure, these are the principal. Few surgical procedure, that is fistulotomy, we cut hold the fistula. Set-on placement, we put a set-on and try to drain, and we can use a cutting set-on or we can use a draining set-on. And a lift, that I told, we will divide the tract in the intersphincteric space. And fibrin glue we can inject. In fact, it has a around 16 to 20% only success rate. So another one is a intraanal endoanal flap we can use. That is also a good result in expert hand. So we'll just see the lift procedure, what sir has proposed, how should do and what should we follow for the lift procedure. So lift procedure, in fact, it has started in 2007. Lift is nothing but ligation of intersphincteric fistula tract. The lift is ligation of intersphincteric fistula tract. There are technical thing about this procedure has been published by Rojanasakul group in coloproctology in 2019. First step is to identify internal opening. We flush from outside either NS or we can use S2O2, and then we do the intersphincteric dissection, incision at the intersphincteric groove, followed by fistula tract hooking we can do, and followed by sutured ligation of the intersphincteric tract, and then curate from outside, close the external sphincter defect also, and close the incision at the intersphincteric level by using observable suture material. So this is the procedure, lift procedure. Usually what will happen, the fecal material goes to the fistula tract and it will cause the infection, and recurrent will have perianal pus discharge. But in case of the lift procedure, we have to go in between the two sphincter and ligate on the both the side, curate outside external sphincter, which will have a good result, good healing. So a non-healing after the lift is also one of the problem is there. What are the predominant causes for non-healing is, one is incorrect identification of the tract. So we should try to do the lift properly. Most important thing during lift is we need to have a good traction by stripping the both the buttock in the prone position. So slippage of the ligation of the fistula tract, that has also been noted. So nowadays Dr. Rojanasakul recommend another reinforcement stitch has to be taken by using 5/8 needle Vicryl 20 and breaching of the anal mucosa. So while dissecting the intersphincteric dissection, we should be very close to the external sphincter so that we will not make another iatrogenic hole in the anal mucosa and also internal sphincter. So incomplete removal of the granulation tissue, we should meticulously curate and core out the fistula tract. If it is a small, we can do distal fistulotomy so that we will not leave any secondary abscess or cavity or extension in the distal tract. And also high transphincteric fistula, we should understand the proper pattern, what patient is having fistula, so that we can give a good justice by the recommended surgery. So I think most of the thing I tried to touch. If anyone is having any doubt, please, I will be happy to answer the doubts. Thank you, sir. Hello.
Hello. Thank you very much, Dr. Jankar, for, as usual, very, very informative presentation. You touch in every aspect that we have controversy about. Fistula surgery is going to be a controversial subject, as always, for everybody. There is different options for dealing with fistula. But you explained very nicely that with fistulas, the first thing you have to understand the anatomy. Before tackling any fistulas or complex fistulas, you have to understand the anatomy. And you are nicely presenting that. And I think our registrar, the senior doctors will benefit a lot from your explanation. Number two, you touch on MRI and fistulogram. I agree with you. Fistulogram is useless investigation, and we are rarely using it now in our practice. MRI, you have to do it with, if you want to do it, we do it when we have a very complex fistula or a recurrent fistula, and you explain that very nicely. I agree with you. The fistula management, the very important thing about fistula management for our junior doctors to understand is that you need to drain the cavity. If you have a cavity, you have to drain it very well, widely drain the cavity, do good curettage, and then you deal with the tract. And you mentioned different modalities for dealing with the tracts. I think also for our junior staff, if you have sepsis and a cavity, you drain the cavity, deal with the cavity curettage the cavity very well, and you can, if you don't know the complex surgery like the lift or the sphincter preserving surgery, you can put a ceton on that tract, and then you come in another session to do the fistula surgery. We have been practicing here in Sudan and been doing something similar to the lift for the last, we started like in 1999 doing that. We do coring of the tract from outside. We core the tract till we reach the internal sphincter or sometimes the mucosa, and then we ligate the tract there. Instead of going between the sphincter, you go from outside and we core the whole tract down to the mucosa, and then we ligate it there, and we have very good result with it. I think for the senior colleagues, as you mentioned, nowadays we are practicing doing the fistulotomy and with immediate sphincteroplasty. And again, we're having very good result doing this type of surgery. But this only for the expert and senior consultants to do this type of surgery. When you do the primary fistulotomy, and then you repair the sphincter. We've been doing this for the last 5 years, and we have a very good result with it, although our cases are not that much, but I think that will be the way forward for the complex fistulas. Again, thank you very much for this nice presentation. And I will ask now, the floor is open for questions and comments. We welcome,
thank you, sir. Thank you.
Thank you, Mr. Jankar.
Thank you very much. Hello, you hear me?
Ah,
Yes, yes.
yes, sir. We
Mr.
hear you, sir.
Suleiman, Mr. Suleiman is a colorectal surgeon.
Hello.
Yes.
Yes, sir.
Okay.
Mr. Omar.
Yes,
Yeah.
Hi,
you can start. Yeah, we hear you.
Dr. Suleiman. I'm a
Yes.
colorectal surgeon at Soba University Hospital.
Yes.
Thank you very much. Thank you very much for a very expert look at a very difficult subject, and really enjoyed it and learned a lot from it. As Mr. Omar, our experience here, probably we are working in a tertiary referral center, and we almost always, the patient referred to are complex fistulae and recurrent fistulae, probably operated 3-4 times. And probably they have had 5-6 sessions of drainage of different perianal abscesses. And our experience showed that initially you have to concentrate on the preoperative workup. And as you rightly said, you have to be very careful about the anatomy of the fistula, and probably you have to exclude other predisposing factors. In particular, we are seeing multiple fistulae. And here part of the workup, which is we routinely do a flexosigmoidoscopy to exclude any Crohn's disease, tuberculosis, or any predisposing factor. And regarding the fistula mapping, the radiological mapping, we are having a problem about standardization of the MRI protocol and the timing of the MRI in relation to surgery. And as you rightly said, if you do an MRI 3 months before and then you operate, there a lot of things may have changed. A lot of abscesses may have flared at that time. So it may not correlate. And the other thing, as I said, it is a heterogeneous pattern of MRI protocols. And our advice here is that it is not a matter of just you routinely ask for an MRI. I agree with Omar that now we keep the MRI, you do it in a special center where they have got an MRI protocol and for selected part of selective patients. Our experience shows that the surgical mapping is the most important. And I'm very pleased to that we are adopting the same classification of surgical mapping and surgical reporting and the post-operative reporting, which is standardized the communication between the surgical community. Regarding just one comment about the lift procedure and our experience with it. As I said, most of the time that our surgery is surgery for complex recurrent fistula with many iatrogenic tracts. And we found it most of the time it is very difficult because of the excessive, very tough fibrosis, which we see it in the perianal region. And you might find it very difficult to delineate properly the intersphincteric space because you are dealing with the just shield of fibrous tissue. And you find that if the internal sphincter is there at all, it is just plastered with the external sphincter, and you can hardly find the beautiful intersphincteric plane, which is make the lift procedure sometimes very difficult. And I think this may explain sometimes the recurrence after the lift procedure. As Omar said, we are teaching our registrars that don't fiddle much. If you find it difficult to do a proper surgical mapping, it is safe to put a seat on and then you come out. And rather than trying to misjudge a high transphincteric fistula for a low transphincteric fistula. And the other thing which I think that very important is the postoperative management. And what my advice for our surgeons who are doing complex fistula surgery, that they have to do the postoperative dressing themselves. And I think that because Most of the time, in the absence of proper digitation of cavities in the postoperative period, and proper irrigation of the wound, and proper drainage, I think this is the common which we found that is the most likely cause of recurrence of fistula. So I think we have to put a lot of emphasis on this part of the management, that the postoperative management don't lose the patient for routine health center to do a superficial dressing or no. The patient, they have to come to the hospital where there is specialized nurse to do that, a well-trained nurse to do that. Otherwise, you have to do it yourself. You have to digitate the wound. You have to irrigate the cavity, drain it well. And that is something which you have to bear with it for 4 to 6 weeks till you make sure that there is a nice granulation healing from the bottom of the wound. But otherwise, you may end with an incomplete healing from the bottom and find that there's just a superficial closure of the skin, and this is another cause of recurrence. So as I said, the primary fistula is easy to deal most of the time, not all the time. But I think the hard lesson and the experience needed is mainly when you deal with a recurrent fistula or a complex fistula. Thank you very much for your talk. I really enjoyed it, and there is a lot of knowledge and a lot of skills in it. Thank you very much.
Thank you, sir. You really well said, sir. I think fistula, we should not take it easy, because one recurrence, it will be a very difficult for the patient and also difficult for the next senior surgeon to tackle that problem. In fact, we all should take a fistula seriously, and we should learn, or we should understand at the first time only in a better way. And also we give a best dedication in the post-op, at least 1 or 2 weeks where fistula is healing proper. If we give irrigation, proper washing in the post-op, that will give a good result for the patient also. In fact, any technique, there is no standard technique. In fact, I will say any surgeon comfortable with whichever technique should continue, but we should give a good dedication also pre-op and post-op. If we do that, it definitely will get a good result in these cases.
Excellent. We have Mamoun Nabre, Dr. Mamoun Nabre from Saudi Arabia. Mamoun, you can unmute yourself and ask your question.
Hi. Thank you very much.
Hi, sir.
Can you hear me?
Yeah, sir, I hear, sir. Mamoun, sir, I hear, sir.
Okay. Thank you very much, Dr. Jankar, for your informative talk. It is very, very, very rich. And thank you again for educating our juniors. And number 2, thanks to SSC for organizing these meetings. And the third thing, to say hi to my teacher, Mr. Suleiman Hussein, and my colleague, Omar Al-Farouk, for this enrichment talk. My name is Mamoun Abre. I'm a trauma GS critical care surgeon. This is best things happening for our juniors to be educated with international staffs and to be communicated with outside world. So just a few things for my colleague, junior colleague. If you see a patient in ER with small nodules in perianal area, don't underestimate it. Take it serious and investigate it. We see these things, and patient coming up with necrotizing fasciitis, forains, gangrene, just because diagnosed wrongly, query hemorrhoids, and sent home with antibiotics, and he came back in septic condition. Don't underestimate these small, tiny, painful things in that area. Can just make an unhappy ending. And thank you very much for all of you for participating. Thank you.
Thank you, sir. Thank you. You well said, sir. Thank you, sir.
Jankar, I also from our experience that I'm always telling the registrar, I just want your thought about it, that in most fistula, especially if you don't find the internal opening, the best thing to do, and sometimes the only thing you can do, is to curate the cavity very well, and then make a good drainage of that cavity after curettage, and then you follow that by good meticulous dressing, and you will find that the recurrence rate is very low if you do these steps. What do you thought about that?
Yeah, it's true, sir. All abscess will not become the fistula. There are few abscess only will become the fistula. So if we are not able to find out the internal opening, rather than meddling and making iatrogenic opening, it is better to drain the abscess and give good wash. There is chance that it may heal. If it is going to have a fistula, then we are going to have a nicely chronic inflated tract, which can be tackled with any particular procedure the surgeon is experienced. So it's not always we should do perineal abscess, we should find out the internal opening. If we are not finding out, it's good. Just we drain it and put a tube inside, or drain it and make a empty cavity, give good wash in the post-op. Definitely there is a chance that it will heal in a better way. But in those scenarios, nowadays there is a trend is coming out. It is abscess is there. We found out the track and also do the definitive procedure. Definitely it is for the senior experienced guys who are there. But if we are juniors are there, it's always better, rather than harming, give best first aid for the patient, drain the abscess. If we have drained the abscess, give good post-operative care. In that also, most of the patient will heal without any forming the fistula. If at all going to form the fistula, we can tackle in the better way in the next setting.
Thank you very much. Thank you. Another comment actually. Thank you, Amar, for raising this point. I think this brings us to the way we counsel our patient for fistula surgery. Don't simplify things for the patient. We say that, okay, it is a very simple procedure. You'll be in hospital for a couple of days and then you go home and then it will heal. No, I think you should have to explain the patient thoroughly that the complexity of the operation, the outcome of the operation, and then you have to explain to the patient exactly that if you try to find the internal opening, you get the fistula tract open, otherwise you are going to put a sheet on, and probably explain to the patient, there is a chance that you may have had another surgery. And this is what we are saying to our junior, that if you don't fiddle, don't try to create a iatrogenic tract. As Umar said, if you fail to find an internal opening by injecting methylene blue, by gentle probing, just stop at this stage, curate the cavity. And then you explain to don't tell the patient that everything is finished. Tell the patient there is a high chance we bring you again after 4 weeks, after 3 weeks, for another EO examination to make sure that it is just a blind tract. Or, as you rightly said, you might find by that time there is a well-matured tract, and most of the time for those such patients, my experience is that you will find in the second session, you will find an internal opening which had been fibrosed, or it had been very tiny, or you haven't been patient enough to find it. And this brings me to the way we handle fistula patients or general anorectal conditions. And I think that this is an operation which shouldn't be left for the junior staff. This should be, unless there is a senior person available. And it shouldn't be put at the end of the operation list. This is something which has to be handled with proper care like any major surgery, because the complications are very detrimental to the life of the patient. Repeated surgery, as you rightly said, being incontinent, having multiple operations. And the other thing which I have to counsel the patient is that don't change the surgeon. That if I explain to them that the success rate is not 100%, and if there is a recurrence, the primary surgeon is the most likely one to correct the recurrence. But if you go for another surgeon, he will try to find his way, and probably this is another recurrence, and then you move to another surgeon, this is another recurrence. So explain to the patient thoroughly that you have to be patient with the disease, you have to be patient with the surgery. The answer may not be in a first operation, the answer may be in 2 operations or 3 operations, whatever. But the idea is that if the operation failed, don't change the surgeon, probably come to the same surgeon, I'm sure he's the right one to correct the first operation.
Yeah,
Can I come in?
absolutely, sir.
I think.
Can you hear me?
Yes,
Rashid. Professor Rashid.
Well, thank you, Dr. Jack. Sorry.
Okay.
Rashid, I'm a general surgeon, I'm not a colorectal surgeon. Thanks for this addressing this very complex problem. You just triggered the nostalgia of Sir Alan Parks, because I think I attended his St. Mark course in 1980s, early, just before. And at that time, he put this beautiful classification of fistula and ano. I have 2 questions. The first question is that how many of your patients have got an underlying cause like diabetes or inflammatory bowel disease? And the second is that what is your advice? Because perianal abscess is a very common encounter in the casualty, usually done by the residents. So what is your advice for a patient coming, for the doctor, patient coming with a perianal abscess? Unfortunately, some of these patients, they think when it bears, that is good, which is, I mean, they come very late, they put some local things on it. But anyway, he is draining a perianal abscess. Does he look for a fistula? And how can he, I mean, do the first job properly? And could that really avoid the fistula?
Yeah, sir, coming to first question, in my last 2 years, I have got 2 Crohn's disease. One was came with a perineal water can kind of perineum, multiple draining abscesses. For that patient, I just drained the perineal abscess and put multiple set on. And near about 9 months, patient was coming to me for daily dressing, and every 15 days coming for the biological. It has wonderfully helped. Another one patient was there, similar kind of the patient, biological was not affordable. The medical guy has put on azathioprine, which has helped. But both the cases, I have not done any surgery. I just drained the abscess, put a set on and came out. So that has helped me, and really I was thankful for medical gastro person to give a proper medication which has allowed to heal it. So coming to second question, if perianal abscess is there, we should not have every case decision that I will going to tackle the fistula. What we prefer here is, if perianal abscess, not ruptured perianal abscess is there, make a small nick in the perianal abscess, try to infiltrate some methylene blue into the abscess and try to squeeze there. And meanwhile, in the anal region, you just see something is coming. If you are seeing something is coming and you feel that comfortably it is a low fistula, you can try. Otherwise, in case of perineal sepsis, it is always better to tackle the abscess by draining. Drainage should be done, thorough curettage should be done. If we are feeling deep cavity, we can put a washing catheter inside. Otherwise, if you feel a superficial cavity, nicely drain and then you just allow them to wash. And it is always better, if a surgeon is new, not confident, residence level, drain the abscess. If surgeon is confident, sure that we are tackling with the abscess with low fistula, you can do the fistulotomy. And in fact, nowadays I have seen whatever I have learned fistula, I have learned from only to these masters, Dr. Parvez and Dr. Arun Rojanasakul. I have seen them doing the sphincter preserving surgery in the abscess also. So it can be possible, but personally, I always prefer to drain the abscess and give a chance and later on tackle for the fistula.
One of our senior registrar, Wala, you raised your hand before. You can unmute yourself and ask the question.
Yes, thank you.
You can unmute yourself, yeah, Wala. Hello?
Yes.
Yes, we hear you.
My question,
Unmute, yeah, Wala, but just unmute yourself. That's it.
I'm having troubles with the internet.
No, we cannot. Okay. For comments or questions?
I think in the chat there is questions, Mr. Omar.
Yeah.
My question, sir?
Yes, we can hear you, Wala. Go on. Voila. Okay, any other questions? We have Okay, there is a question. Is there any role of SITS path in the post-operative management? Dr. Jankar, somebody asked, is there any role of the SITS path in the post-operative management? Jankar is connecting.
Hello, sir. Can you hear me?
Yes, we hear you now.
Yeah. Sorry, sir. I got disconnected.
Sir. Yeah, there is a question. Is there any role for the SITS path in the post-operative management?
Sir, I couldn't hear, sir. Any?
The question is any role for SITS path in the post-operative management, SITS path?
Yeah, sir, usually 2 to 3 times we recommend a sitz bath, and it is a lukewarm water using a betadine. We tell them to mix the betadine and use a lukewarm water. And importantly, when we are doing the sitz bath, try to contract and relax the perineal sphincter so that anything is there in the even anal canal above the dentate level, that will get cleaned nicely.
There is another registrar asking, do we have to tackle the fistula with the abscess as an emergency, or we deal with the abscess first? I think you answered that before.
Yes, sir.
Yeah.
But we always should consider as an anorectal sepsis rather than defining abscess or fistula. We should take as a complex as anorectal or perianal sepsis. Depending upon the present scenario, we should tackle that scenario.
Excellent. Any more comments or questions?
Dr. Yasir, you are welcome, Dr. Yasir.
Hello.
Yeah.
Hello, Professor Samrat Yasir Shambati, General Surgeon. Thank you very much for this presentation.
Thank you, sir. Thank you.
My question, have you any experience about the laser management of the fistula? Number one.
Laser is one of the energies, sir. The principle of surgery has to be followed. Laser is technically, it is an energy source. We are using conical, but whatever I have understood from the laser is, there also the technique, either someone is doing a submucosal ligation and then putting it outside. It's basically, it is handling the distal tract. But most important management of the fistula is a proximal at the level of internal opening, at the level of internal sphincter, or in between the two sphincter. That area is more important. For that, we need to understand the major patterns. We need to understand the pathophysiology. Maximum whatever has been told in the laser is that is mainly to handle the distal tract. But I personally don't have much experience about the laser, but it is another one surgical procedure. If we use it, we'll get. If we are expert in that, if you are doing frequently, if we are getting the result, we can use it.
All right. Second question, the patient with the recurrent fistula 3-4 times, do you resort for any defunctioning colostomy or ileostomy?
No, sir. No. We should not prefer, because anorectal fistula or perianal sepsis is a benign condition. Until and unless we are having a bad perineal sepsis, which is endangering a life, we should not touch. That was I explained. Perianal sepsis patient came with water can, I don't have picture to share now, but multiple opening were there in the perineal region. That patient also, we just drained the abscess. We have given proper antibiotic care. It has healed. Crohn's disease patient can heal in the perineal sepsis, means any patient can heal. We should avoid, because it's not a malignant disease. It's a benign disease. As much as possible, we should not step in for the defunctioning colostomy. You take care of perineum, it will give a good result.
All right. Number 3, what type of the seton? Cutting seton, or like just you put a seton for drainage and later on you come to manage?
Yeah, usually preferable is a drainage. If you are having perineal sepsis with inflammatory bowel disease, drainage seton is we don't prefer. Whatever I learned from the masters is, we don't prefer the cutting seton. And whatever 2 patients I have used is, those are the simple draining seton to drain the abscess, avoid forming the again perineal sepsis till the time that biological or management of IBD medications are working.
All right, thank you very much.
Thank you. We have
Professor,
questions.
I think Professor Jamal Al-Shallali is raised his hand.
Just one question from the registrar. Endoanal ultrasound and manometry indication in management of fistula in anal.
Sir, endorectal ultrasound is a subjective dependent. In fact, we had a radiologist in our hospital, in GEM hospital I was working, which is my training center. There one radiologist who used to do good endorectal ultrasound. But again, same thing will come subject to subject, radiologist to radiologist, the finding may vary. But I feel like UAG in abdomen, CT in abdomen, if we are doing CT for major cases where we don't want trouble, you will be more happy that how we are going to have. But here also it is the available modalities MRI. The cost of MRI investigation, if you take a recurrence and operating on the patient, it's compared to that, it will be less only. If you are feeling complex fistula, rather than doing anything else, it should be done MRI. But best hand trust is also having a good preoperative reporting. And coming to next question, manometry. In fact, manometry, if we feel that you are not having good resting tone, you are not having good squeeze pressure, if you want medical aspect to note down manometry and perianal tone, you can do it. But in those cases, I have seen if we do a proper fistulotomy with sphincter repair on the table, that will give a good result for the patient.
Excellent. I think, as you rightly say, manometry is not a routine thing we do in fistula surgery. We only do it if the sphincter is questionable before the surgery, and sometimes you do it if you, as Mr. Jankar say, you medically want to protect yourself, so you have to do it just to assess the sphincter before you're doing your surgery. Okay,
we have
yeah.
Yes. Yes, thank you very much, Dr. Jankar, for this very interesting lecture. And I am a general surgeon. I would like to commend really, I like the way that you have introduced your new classification.
Sir, sorry, this is not my classification. It belongs to Dr. Arun Rojanasakul. We all should be thankful for the person who has shared, because he is one of the so generous professor. He has taught 2 days. I feel, I hear announce everyone that these are the two guys are doing extremely good. Dr. Parvez Sheikh's, his operative is excellent, and Dr. Arun Rojanasakul, his thoughts are excellent. If you get the chance, visit them 1 or 2 days, spend them, because these people are generous to teach. And in fact, today, whatever I am able to present, a lot of things I have got from them, and his thought is to share with others, so that let them, everyone have good concept of the fistula. And if you want to thank for the presentation delivery, it's okay. If you want to thank for the concept, that thanks should go to Dr. Parvez Sheikh and Dr. Arun Rojanasakul.
And also for you for transmitting this knowledge.
Yeah, thank you, sir. Thank you.
First time for me, honestly, to have seen or heard about it. And I think it's very useful. My question, I usually deal with the commonest type, which is the low fistulas. And yes, I tend to prefer to do fistulectomy rather than fistulotomy, which is removing of the whole tract. But this will end with a rather larger wound than that of fistulotomy. Just to let my registrars understand what I mean, fistulotomy is just cutting over and deep just to open the tract. And fistulectomy is to remove the whole tract. So I usually do fistulectomy. My question is, what is your preferred operation? Do you still do fistulectomy in your institute? This is the question number one. Number two, if you do fistulectomy, would you have you any experience with closing or suturing it primarily rather than keeping it open and dressing the wound for 4 or 6 weeks? Thank you.
Sir, preferably the fistulotomy, both are serving the same. Personally, I feel that's what I am feeling. The fistulotomy and fistulectomy, you are taking out the infection. In fact, it is infection. Curate the wound, clean the wound, open the wound, lay open the wound, curate the wound. If we are taking out the infective material, so it is not like the cancer or something where we need to be radical and take out. Here, purpose is to open the wound, but both are mostly equal. Only issue is if we are not very much good in the procedure, we may tend to overdo, which should be avoided. If at all it is going above the superficial external sphincter, going to the levator, in those conditions, if we are generously trying for fistulectomy, it will harm in junior hand. But if we are planning for simple fistulotomy and curating the wound, it may also serve the purpose. I feel that's what we practice. Either we do sphincter preserving surgery, or if it is a low intersphincteric, low transphincteric, we will plan for fistulotomy, curating the wound. But nowadays, after last 6 months back, I have visited Dr. Arun Rojanasakul sir 1.5 years before. But last 6 months back, I have visited Dr. Parvez. He is a one person who does only complex fistula. Simple fistula, he will tell that you go and operate at any other place. What the sir does is he will take complete fistula, and he is so confident to suture every sphincter. If we are that much confident, we should go for that procedure also. That is not wrong. And nowadays we are planning, we are doing for a low transphincteric or low intersphincteric fistula, trying to do fistulotomy, curating the tract, nicely cleaning everything, and we are taking 2-stage, because the approximation of the wound will help to reduce the pain in the post-op and also will help to heal better. That might be a good one.
Yeah, thank you very much, Dr. Jankar, for this nice presentation. I think there is a lot of question and a lot of comments, but I think we have to finish now. And
Thank
we
you,
hope
sir. Thank you.
to see you again with this very informative and nice lecture. Thank you very much.
Thank you, sir. Thanks a lot.
You,
Thank you
everybody.
for giving
Thank you,
opportunity.
everybody.
Thank you, sir. Thanks a lot,
Thank you,
sir.
everybody. Thank you.